Hello, my name is Yihua Yue. I am a PhD student in epidemiology at University at Buffalo. Today, I am presenting my project entitled Association Between Dietary Patterns and Periodontal Disease, the OsteoPerio Cohort Study. Periodontal disease is an infection that occurs in the supporting tissues of the teeth. As we can see by the image on the right, periodontitis, which is a late stage of periodontal disease, has some symptoms including receding gum, inflamed gum, deepening pocket, and bone loss. Periodontal disease has a high prevalence, and it ranks the 11th most prevalent condition in the world. Periodontal disease is the leading cause of tooth loss and is associated with systemic diseases. Some nutrients and foods have been found to be associated with periodontal disease. Dietary pattern compared to single food or nutrient can reflect the combinations of foods and nutrients of the overall diet. Score-based dietary patterns can evaluate the adherence to certain dietary patterns by assigning scores to healthy components and deducting scores to unhealthy components, and it can then derive an overall dietary pattern score. So far, no study has examined the association between score-based dietary patterns and the progression of periodontal disease over time. In this study, we examined the association of adherence to score-based dietary patterns at baseline with prevalent periodontal disease at baseline and the progression of periodontal disease during follow-up. We use the data from osteoporosis and the periodontal disease study as known as OsteoPerio study. OsteoPerio study is a prospective cohort study consisting of postmenopausal women who were recruited from Women's Health Initiative observational study at the Buffalo, New York Clinical Center. Dietary behaviors were assessed at WHI baseline and OsteoPerio baseline, and periodontal status was assessed at the OsteoPerio baseline and follow-up visits. Participants with missing data on periodontal assessment, missing diet data, or with extreme allergen intake were excluded from the analytical sample. Details of sample selection are presented in the flowchart on the right. Dietary behavior was assessed from Food Frequency Questionnaire, FFQ, which measured the frequency and portion size of each type of food they consumed. 4 score-based dietary patterns were used in this analysis: Healthy Eating Index, HEI, Alternative Healthy Eating Index, AHEI, Dietary Approaches to Stop Hypertension, DASH, and Alternate Mediterranean Diet, AMAD. Dietary pattern scores were calculated from the average intake of WHI baseline and OsteoPerio baseline in order to estimate the habitual diet over 3 years, leading to OsteoPerio baseline. At each visit, 4 clinical measures of periodontal diseases were assessed by dentists: alveolar crestal height, clinical attachment level, pocket probing depth, and the percentage of bleeding on probing. From the image on the right, we can see these measures reflect the gum inflammation, gum recession, and bone loss. The bigger these values, the worse the periodontal status. Moreover, missing teeth and reason for missing were recorded. In the baseline cross-sectional analysis, we use a linear regression model from continuous measures, including chronic indicators and acute indicators. And we also conducted logistic regression models for prevalent missing teeth due to periodontal disease. In the prospective analysis, we conducted a linear regression model for chronic measures, and in the models, we adjusted for the baseline outcome measures to estimate the progression. Participants with severe periodontal disease may lose their teeth during follow-up. When the worst side was removed, their overall mean measure will be improved, which means their progression will be attenuated. In order to reduce this bias, we conducted sensitivity analysis by adding 10 millimeters to the crowning measures at baseline for each tooth lost over follow-up due to periodontal disease. And then we rerun the linear regression models for the prospective analysis. We conducted logistic regression models for definition-based progression of periodontal disease. It was defined by ACH and assessed by oral radiographs. We also conducted a logistic regression model for new missing teeth due to periodontal disease. In all regression models, we adjusted for age, race, physical activity, neighborhood socioeconomic status, smoking, education, hormone use, frequency of brushing teeth, frequency of flossing, and frequency of visiting dentists. Table 1 presents the cross-sectional associations at baseline. Dietary pattern scores are on the top and the periodontal disease measures are on the left. We can see that the most beta coefficients are below 0, and we observed a statistically significant association between better adherence to HEI and AMAD and lower CAL and lower percentage of BOP. In addition, better adherence to HEI- and AMAD was associated with lower odds of having missing teeth due to periodontal disease. In the prospective analysis during 5 years of follow-up, better adherence to AHEI and AMAD was positively associated with greater progression of ACH from baseline to the 5th year, which indicates more bone loss. Then we conducted sensitivity analysis accounting for teeth loss. And then we can see most beta coefficients decreased and the positive association no longer remained significant. In prospective analysis during 17 years of follow-up, better adherence to AMAD and HEI was positively associated with the progression of ACH and CAL respectively. After accounting for tooth loss due to periodontal disease during follow-up, the positive association no longer remained significant. Our study has some strengths, including large sample size, long follow-up, comprehensive periodontal assessments, multiple diet assessment, and public health significance, because our study sample is a high-risk population for periodontal disease. On the other hand, this study has some limitations. FFQ has a nature of measurement error, and we can't avoid social desirability bias and seasonal variation. Our sample consisted of women who were highly educated, practiced good oral hygiene. This homogeneity makes it difficult for us to observe the difference. Lastly, it's possible that women may change their dietary behaviors during follow-up, which can cause misclassifications of their dietary behaviors. In conclusion, from this study, we found that better adherence to dietary patterns was cross-sectionally associated with better periodontal health at OsteoPerio baseline. Better adherence to dietary patterns was prospectively associated with more progression of periodontal diseases over follow-up. However, incident tooth loss due to periodontal disease during follow-up may explain the observed positive association. I want to acknowledge the co-authors of this study, collaborators, funding sources, and all participants enrolled in OsteoPerio cohort. If you have any questions, please feel free to contact me. Thank you for your attention.